self-advertising here. I'd be happy to take questions.
Just make sure they repeat. Thank you so much, Dr. Miklowitz. That was just a terrific talk. Very practical, don't you think, and very helpful. Did it hit the mark? Good. I think we have some opportunity now for some questions and some dialogue with Dr. Miklowitz. So if you have a question, could you stand up and try to speak loudly, and we'll actually repeat it for everybody.
The question the gentleman asked is about as the days get shorter, we head into winter, if you have bipolar disorder, what are some good things to do? Light box. You can get these light boxes, or sometimes they're called dawn simulators that go off in your room and mimic the light that you would ordinarily get. Some people decide to get up earlier and experience more of the day, go outside, get exposed to light at 7 in the morning instead of at 8 or 9. Try to spend more time outdoors if you can, if your job or life allows it, and try not to fall in the pattern of oversleeping, hibernating, which is what most of us want to do in the winter. The question is, do high periods of blood sugar trigger episodes? Not that we know of. We do know that people with bipolar disorder seem to have higher than the average number of people with diabetes. I didn't say that very clearly. The co-occurrence of bipolar disorder and diabetes is fairly high, and I think that's partly because the medications cause weight gain, and some people develop diabetes as a result of it. We don't know that excessively high blood sugar leads to mania, but we do, on the other hand, encourage people to have a pretty balanced diet, because that in itself helps mood. Not to eat too much sugar, not too much caffeine, all the things you would usually suspect. Okay, the lady is asking a question about childhood bipolar disorder, we refer to it as bipolar disorder or mood disorder. Not necessarily. There are kids who have bipolar 1 or 2 disorder, meaning they have the full syndrome even though they're not even 18 yet. And we've seen that in kids as young as 9 or 10. There are some people who say they see it in 5-year-olds. I have not seen such a kid. What I do see a lot of, though, in kids is a kind of undifferentiated mood disorder state where I see depression, I see anxiety, I see a little bit of mania, but not a full manic episode, maybe a little bit of learning disability, these kind of cases that look like kind of a mishmash of a lot of different things. We see that, that's kind of our bread and butter in our clinic, in fact. And we call that mood disorder because it hasn't declared itself as bipolar disorder yet. So semel.ucla.edu/champ, there's a blog on there. There are a lot of informational sources. And at the end, you'll find space. I don't have them up there yet, so that you won't find them tonight, but in a day or two, you'll find them up there, and you can. Sure. Yeah, it's a good question. I'm not familiar with the organization, the position you're talking about, Matt Cry, but I would like to read more about it. I can tell you that there are people whose lives have been saved by medications. I don't have any doubt about that. I've had patients like that I don't think would have lived if they hadn't been on medications. I also agree with you that the pharmaceutical industry overemphasizes medications, and that life ills are viewed as treatable with pills. And of course, that's a very Western idea. That's not something you see as much in Eastern culture. The more Buddhist view, for example, is more about acceptance and living your life. But at the same time, people are in incredible pain, and I think we do what we can, and that's usually a combination of medications and therapy and lifestyle management. Oh, type 1 is type 2. Okay, yeah. That causes a lot of confusion, doesn't it, bipolar 1 and 2. Bipolar 1 are people who go back and forth between severe depressions and full-on manias, where they have all those symptoms I described with elated mood, irritable mood, grandiosity, decreased need for sleep, increased activity, but they also usually have severe impairment in their day-to-day life. So they end up getting arrested, they end up in the hospital or in jail or something, losing their job. You can definitely see the impact of the mania on their behavior. People with bipolar 2 go back between depression and what we call hypomania. Hypomania is a less heightened, activated state. It's still above normal, and you can still see it, especially if you're a family member. But if you met the person on the street, you might say, well, there's a person who talks a lot or walks fast or is full of ideas. but you wouldn't necessarily say they're psychotic or need to be in the hospital. And the difference is bipolar 2 is a more depressive type of the disorder. It's less destructive in the manic phases, but the depressions can be quite destructive. So even though you may have bipolar 2, you may still have some of the same needs treatment-wise as someone with bipolar 1. Yeah, the question is, can you, if somebody's had multiple episodes and then goes off medication and then is well, is that what you're saying?
Over a 10-year period.
Over a 10-year period. I have seen it happen where people go off their medications and they're okay. I think it's a high-risk situation. If I were going through multiple hospitalizations and I were taking medicines and I had some evidence they were working, that they were the right medications, if I were really strongly wanting to go off of them, I would do it in a very systematic way. So, for example, I might say, I'm going to meet with my doc on a weekly basis while I'm going off of them to make sure that I don't develop symptoms. I'm going to make sure people around me know what an episode looks like. I'm going to make sure I have an open dialogue with my doctor so I can get back in to get care again if I need medication. I wouldn't just go off of them and then just disappear, because, to be honest, people who go off of their medications quickly have more relapses sooner, on average. But are there people who have been able to get along without medicine? Certainly there have. Do you need psychotherapy for the lifetime? No, not necessarily. What I usually recommend is people have, after they've had a few episodes and they kind of know what the illness is like, have a therapy where the therapist goes through with you what the triggers have been, what the early warning signs are, what family relationships have played a role, maybe get family members involved. What I think actually helps quite a bit are monthly check-ins. At some point, if you've had your therapy, you're stable, you're taking your medications, you've got a job and so on, you may not need weekly therapy. But a check-in is always a good idea. There's somebody who knows what you're going through and knows your history. And I have people who've been getting check-ins like that for years and years. Is it necessary? Not necessarily, but people, I think, often like to, because that's the one person who knows their history, if they can afford it. Yes, please.
Sure, thanks. As a psychiatrist who prescribes medications and has seen people over long periods of time, I think it could be really valuable if you can find a psychiatrist that's also interested in some therapy.
Yeah.
So when you go in for a session, the psychiatrist is very interested in things like your sleep-wake cycles and how you're handling stress, and maybe give some tips or coaching, and gives a sympathetic ear instead of just writing the medication. And I think that's a nice model if you've had another therapist. So for example, if Dr. Miklowitz and I were working together, he might see the patient in the early stages and do family work or some more intensive work, and then after a period of time, might sort of hand off the treatment, if you will, to a psychiatrist who could see the patient monthly, or even ultimately maybe every 3 months if everything's been stable for many years. But that's a nice model, and if I were a consumer, I'd be looking for that in a psychiatrist.
Yeah, that's a very good point, and I would add too that I think it's easy to assume that the doctor, the physician, is going to be doing the medications and you got to go somewhere else for your therapy. It may be the same person, and I think it's certainly more economical if you can get the same from one person, but that isn't always possible. So a history of self-medication and
Addiction.
an addiction.
Into addiction.
Yes. Okay, so if somebody is, and what's the addiction to? What drugs?
Pot and meth.
Uh-huh, okay. So I think you're not going to get very far at all with psychiatric medications until the meth stops, because the meth is going to make it impossible to respond to mood stabilizers, atypical antipsychotics. So I would recommend a detox or chemical dependency program first, before I even tried to treat the bipolar disorder. In the case of someone who's a chronic pot smoker, a little different. You might start with the same kind of psychotherapy and education and try to figure out what role is the pot playing. It may not be self-medicating. It's easy to say, okay, well, they have mania and depression, so they're smoking pot to get rid of it. It can also be that when they're manic or depressed, they do more of everything. They eat more food, they have more sex, they drink more alcohol, they smoke more cigarettes, they smoke more pot. And you may want to find out, is it sort of a habitual, sort of appetitive diet that the person is after, that they're trying to satisfy? What role does the pot play? What does it help them do that they can't do if they're not? and ask them to experiment with what's it like a day without smoking pot? What do you feel? How's your sleep? How's your mood? Use themselves as their own experiment. Right, so rapid cycling is an interesting phenomenon. For those of you not familiar with it, we define rapid cycling as people have 4 or more episodes in a single year. Although I think when people talk about rapid cycling, they're often talking about having episodes even daily or every once a week and so forth. First, we have to rule out thyroid abnormalities, because there has been in some patients a link with thyroid abnormalities and rapid cycling. Second, if there's an antidepressant in the picture, we usually stop it. If somebody starts rapid cycling and they're on an antidepressant, the antidepressant may be the culprit, not necessarily, but that's one of the things we would stop. Probably we would change medications. If the person's not doing well on lithium or Depakote, we might try lamotrigine or one of the other medications. If it's a chronic rapid cycling depression, we might treat that differently than a mania. The other thing we would tell the person is, in all likelihood, it will mellow with time, because rapid cycling is not a lifelong phenomenon. It tends to be for a couple of years when the person is restabilizing, and then they stabilize again. Yeah. Does living in a family where you have a bipolar parent, does that make someone bipolar, for example, by modeling their behavior? Not apparently. Only because there are a few of those twin studies where people are raised apart and they still have high concordance rates between identical twins, even though they weren't raised in the same family. I don't doubt that being raised with a bipolar parent can be very difficult, but it really depends upon whether the person's stable or not. If the person is stable, then I think the person can have a fine childhood. If they're constantly in and out of episodes in hospitals, of course that's going to be traumatic and anxiety-provoking for the child. But will it make them manic? Probably not. Not if they don't have the biological vulnerability.
I'd like to ask one last question, if I could. From your perspective as a researcher and your knowledge of other researchers around the world working on this problem, do you have some thoughts about the future and what hope we might have for people that suffer, for their families, on what kind of breakthroughs we might see as we look toward the future?
Okay, that's a good question. I think all of us are holding our breath to see what the healthcare system is going to offer us and how that's going to play out in mental health in general. In terms of research, I think it's probably going to be the case that we're going to start identifying the genes that are consistently related to bipolar disorder. What we do then is not entirely clear to me, because I know that often in genetics research, I don't know if you have the same reaction, but the premise is if we get the gene, then we'll know the treatment. And I don't think that's necessarily true. There may be a long period of time between identifying the gene and finding an appropriate treatment. Right. New drugs are being tested all the time. New psychotherapies are being tested. And also I would put a lot of hope on brain imaging studies that are really identifying where is emotion processed in the brain, what are the triggers for emotion processing, and at some point we may be able to know what triggers can be controlled and which can't. That's what I'd like to see. And also, finally, prevention studies. People who, can we identify the kids who are at risk and do an intervention that might prevent it from occurring in the first place. That would be my hope.
Well, thank you very much. It's nice to end with some ideas.
Thank you. Thank you very much.